Okay, well, welcome. Thank you so much for joining. I'm talking today about a topic very, very close to my heart, which is access to healthcare. And when we're talking about access to healthcare, at the end of the day, everyone, this should not be one person's point of view or another person. This should be an American point of view, that everyone deserves access to quality primary care regardless of their ability to pay. They should all be treated the same regardless of their ability to pay. And when we're talking about access to healthcare, we're not just talking about putting up a building with doctors and nurses in a neighborhood and then automatically think that that will fix all of healthcare's problems. It's much more deeper than that. I remember from my days of being a community health doctor, constantly we would be running into this situation where people in the community would be asking me, why are your patients going to the emergency room? And I remember thinking at the time that it was something that was unique to Tampa. Well, why is it that half of all people in the city are getting their medical care in the emergency room setting? I later ended up finding out that half of all medical care in the country is in the emergency room setting. And the main driver of that is access. So today I'll be talking with Robert about the barriers to care, and when we're and specifically with how telemedicine and telehealth in general is normalizing all the disparities that have been in our system for years that are all being exposed now because of the coronavirus pandemic.
Yep. So Faisel, I think we're certainly in alignment on the importance of affirming the fact that everybody should have access to primary care services. It's something that I think we have to establish if we're going to talk about how we can start to move forward to improve access to care. But right now in the healthcare system, I worked for the Institute for Medicaid Innovation for about a year and a half, and we talk a lot about barriers to care in the Medicaid population. But there's also barriers to care for lots of people across income levels, across socioeconomic statuses, across varying population groups and urban and rural groups. So some of those common barriers, there's about 6 of them I have written down. So what I think we should do is I'll walk through them, and then let's see how you've seen them in your clinical practice.
Sure.
So I think the first big barrier is cost. Do I want to spend money on going to the doctor? Can I afford to go to the doctor when I might choose between food or housing and seeing my physician? So where have you seen that in clinical practice?
Well, there's two general areas, 2 general groups of people I think of immediately. Number one, we have the uninsured in the country. So as a whole, for about 330 million people, we spend about just over $3.6 trillion for 330 million people. And despite spending all that money and the amount of money that we're spending, if you added up the next 9 economies on the planet, it would equal that. So, because, in America, we're so used to throwing around these huge numbers like monopoly money, billions and trillions and all this. I mean, let's put it in perspective. The next 9 economies in the world, their economies combined is what we spend on healthcare. And so despite spending all that money on healthcare, we still have about 30 million Americans who don't have health insurance. So there's definitely that group of people who don't have health insurance and the uninsured. And then you have low income people who are earning low incomes, many hourly people who cannot afford to take the time off of work in order to get primary care services. So I would like to break it down to those 2 groups of people. And we know the statistics. I mean, I know that amongst, like I say, right now we're getting into the flu season. So I'm really passionate about getting the flu vaccine, making sure as many people are vaccinated against the flu. And we have studies that show repeatedly over and over again that is somewhere around 10 to 15% of people who are uninsured are the ones who get vaccinated against the flu. You end up having a massive number of people who don't get something as simple that's readily available. I mean, there's not a pharmacy in the country or a grocery store in the country that's not offering the flu vaccine. Yet we still can't get more than half of American adults to get vaccinated against the flu.
Right.
So definitely with regards to the cost, I would like to divide it into the people who are uninsured, which is a huge chunk of people, about 30 million people. And then you have people who are earning low incomes who cannot afford to take off of work in order to get the primary care they need.
Yeah, and that's a huge problem when we're talking about, trying to make sure people are healthy and to be sort of practicing preventive medicine and to try and keep people on a good path to health rather than, letting them kind of spiral out of control and end up with really costly services down the road. So I think the general consensus is ensuring access to care is important for an investment in long-term health.
And with telemedicine, we're able to bridge a gap in both populations. Yeah. If you can't leave work, but you can take a 10-minute break to get on the phone with a doctor, and now with hotspots and just access to internet and the access of being able to do these types of video calls, I'm establishing patients right now virtually. There's a group of there's a population of patients in St. Petersburg. I'm in Land O'Lakes, Florida, and I'm establishing them completely virtually. And this is my world, the geriatric world, which we should probably talk about. Another group of people who are impacted by access are the elderly. And you wouldn't think so. You wouldn't think that the elderly are negatively impacted because of having Medicare and all the different Medicare programs and even having Social Security and all. But if you look at mobility within their homes, and also the ability for many seniors to be able to get to the center. Short of actually going to pick them up. Even to go to send a driver, we send drivers, we Uber patients, that's something that, but just to get them there, there's so much risk with decreased mobility. So that's another chunk of patients who are impacted negatively with negative access.
Yeah, so I think you've touched on two of those really important barriers. So we have transportation is the next one. People who just physically can't get to an appointment, it's tough for them to access it. And then there's time restrictions. So for people who might be working, I think about even myself in this situation. Like if I'm working, maybe I have to take off PTO to go to a doctor's appointment when they're not open past 5 o'clock. And so that's a big access barrier across the population. Would I like to drive across town and go to the clinic? Or do I have access to a car to do so? So I think those two are really important additional barriers. The obvious one that we've talked about is geography. So people who might not have a clinic near them, you actually have to take a whole bunch of time to go to a clinic. You might have to drive 40 minutes to get there. And then are you going to choose to do that? That's one of those issues as well.
Yes. And with transportation, when I think about the public transportation system of a city like New York City, you don't even need a car to be able to get around New York. But then in Tampa, with our public transportation system, which is very similar to many cities across the country, a simple 10 or 15-minute car drive on the bus, on taking different buses, can take up to 2 to 3 hours just for a 15-minute car drive. And when you're thinking about the populations of people who are relying on public transportation like that, where would the incentive be for them to take time off of their day to be able to come take all this transportation, come into the center in order to get something as simple as a flu shot?
Right.
And that's one extreme. And then you have us. People, even I think about with getting the flu, I believe in the flu shot. I know the importance of the flu shot. But if it wasn't made ridiculously simple for me by ChenMed, where I just know I just go to a meeting and, here, you got to sign this up and you get it done and over with. I mean, it's got to be really simple in order for even people.
All the doctors can give each other flu shots when you're in the office.
Yeah, right. But
but people do have to take a long trip. Yeah.
Well, I was saying that there's somewhere over 3 to 4 million Americans who struggle with just basic transportation. Services.
Right. So, and then I think one of these other access barriers that I want to kind of end with here before we jump into talking a little bit about how virtual care might be able to bridge the gap for some of these barriers, as you already touched on. But there's distrust sometimes in certain populations of the medical care system for historic reasons. And so sometimes that is a barrier to care. People don't want to go in there in the first place. They might live next to a primary care clinic, but they don't trust the people who might be there to treat them with respect. So, what do you think about that?
We definitely need to engage people. I found it in the community health center world. Well, one of the reasons I wanted to do deep dives to find out why are people going to the emergency room when they have a clinic that's within a few miles of their home. And actually, the emergency room for many of them was within walking distance or bike riding distance, rather than coming to the center itself. And because people are getting most of their medical care in the emergency room setting, there's a culture. I don't know if you've ever been in the emergency room before. I have as a patient, and it's a very sterile environment. You know, you may be going over there for a headache, and in medicine, we like to refer to things as, you know, the headache, treat it like the horse that it is. But if you go with a headache to the emergency room, they're not going to treat it like a horse. They're going to treat it like a zebra. Right. And the process of being managed by something as simple as a headache in the emergency room setting is vastly different than the way that you'd be managed in the outpatient setting. So that further adds to the distrust. And then when you have situations like us right now in the medical world and the political space as well, trying to navigate through how to manage COVID as we're learning, how to respond to this disease, it's very confusing for people. It's very confusing, especially the ones who had doubt in the system to begin with.
Yeah. I mean, even the scientists are arguing with each other, which is part of the scientific process, right? Coming up with what works. People disagree. They do bigger studies. They do studies to prove their points and their hypotheses. But, you know, it's a process that takes time to be able to gather the data and to be able to analyze the data and to be able to say, you know, this is what works, this is what doesn't work. And a lot of times you have varying viewpoints that get publicity, and people are like, well, I don't even know who to trust. I don't trust anybody. Who's telling me the truth?
Especially
and I think that is
good news doesn't get the word out. You know, the society as a society, we enjoy the more dramatic news, and especially when it's concerning the doctor-patient relationship. So if we had to look at the doctor-patient relationship being strong, we're at a place that's way on the opposite end. And I feel that with telemedicine, we can restore that doctor-patient relationship. I'm seeing that happen right now, where patients have even patients who never have FaceTimed their own children or grandchildren, and they're having their first FaceTime experience with me as a doctor. It is a very intimate relationship when you're having that call with your patient when they're in the comfort of their own home. I mean, I have never experienced this level of the doctor-patient relationship prior to getting into this telemedicine space.
Yeah. And that's one of the critiques that people say. It's like, oh, how can I have a doctor-patient relationship? In my next book, I actually have quotes from you talking about this intimacy that you feel when you're actually providing services via telehealth or virtual care. So while it does improve access, right, some of the common critiques or myths are that, like, you can't establish a good relationship. And you very firmly believe that, like what we're doing right now, like I feel like we are having a conversation, we're building a relationship, we've been doing this for a couple of weeks. So just like a patient and their physician, it's something where you still get to interact with people. You get to see that facial expression, you get to see and experience empathy with the other person. And I think that takes time to educate, you know, the system and other physicians about, but I think patients see it immediately.
You know, when you talk about the trust and what the patients feel, if patients right now and across the country, it takes about a month to get in to see your primary care doctor. But with this technology, suddenly we become accessible to the patients when they need us. And that's how you start building trust. You see, right now, patients and just the society as a whole don't feel that they can trust their doctors with the little things. And we as physicians expect us, well, why didn't you call me? Why didn't this is human nature. No one will trust anyone with big things if they can't trust you with the little ones. And I feel that with telehealth.
And I think that goes.
No, sorry, I was just saying that. I just feel like with telehealth, you're bridging that gap because suddenly they don't have to wait a month to see me. They can just call me right when they need me.
Yeah. My first book, the subtitle is Bridging the Gap Between Health System and Patient. I love when you keep saying bridging the gap. I was like, that was a good choice for me. But I think the thing is that for at least my perception of healthcare services, it goes back to access. You are conveniently accessible via this medium. But the other thing is in terms of cost, like I might not want to call you with the little things if I think I'm going to get charged for it. Like, is this worth me going to the doctor and paying for it? Like, is this that big of an issue? And access is also making sure that, you know, there is sort of this access to long-term care and care for patients to be able to get educated and to ask clinicians what what is going on with their bodies and to be able to understand their conditions. And I think that cost barrier, even for just a little thing, because we've made healthcare so transactional under fee for service, it makes people ask the question, is this worth for me to ask the question, when it probably is worth that, which is what the power of value-based care is as well.
Yes, because as a society, we are still a very reactive society when it concerns health. Our society does not incentivize prevention or early intervention. And because of this being so ingrained in us, that, well, as long as I'm still functional, as long as I can still operate, I'll still go to work. You know, that rather than putting all the emphasis on prevention and early intervention. So far as the doctor-patient relationship is concerned, if we don't have a strong doctor-patient relationship, we're here at this extreme. So as a society, we need to first stabilize the health of the society. That needs to happen, because we're not doing a good job of stabilizing health either. If half of all medical care is being delivered in the emergency room. So the first step would be to stabilize health, especially the chronic medical disease, and then incentivize prevention. Like in my world, our doctors have over 90% vaccination rates of their panels with the flu. And they couldn't imagine waiting for patients to get sick. I mean, we know as physicians, like if you're just talking about the flu, that patients shed the virus for 3 to 4 days, even prior to having the first symptom. So of course, the strategy should not be to wait until they become symptomatic and then prescribe a medication. God knows how many people are impacted. You want to vaccinate them and get ahead of it.
Right. And we want to do that across conditions when we can.
That's right.
And we want to make sure that we're promoting that. Absolutely. Right. And telehealth is a way that you can encourage that to happen by making it convenient. And that combination between telehealth and value-based care, like the situation you're in, is extremely powerful. It's the relationship I talk about in my first book, which is, value-based care is big innovation in payment policy. It changes the incentives entirely. And then it also incentivizes sort of some of these new technologies and care models to be developed that might solve a lot of the problems we have existing in the system right now.
I'd love to do a little bit of a deeper dive into value-based care and like basically your first book, the intersection of value-based care with virtual care. Well, we thank you for joining us this week and look forward to seeing you again next week.